Professor Steve Moeng, who is the Professor of Surgery at the University of Witwatersrand, Johannesburg, who is also the academic head of the trauma unit. And he is the trauma surgeon at this CMJAH and the Milpark Hospital, as well as the president of the Trauma Society of South Africa, the chairman of the STC, and the previous chairman of the ATLS Gauteng. So we'd like to welcome Dr. Steve Moeng.
It's an honor to be here, and I hope that what I'm going to share with you will add into some of the insight and follow on the presentation that was given earlier on. The way and the layout for my talk will be based on the issues relating to a case presentation, because again, all of us dealing with these issues and dealing with trauma in the pandemic, there are certain things that we need to be clear about and to be able to realize and know well that they do exist. Then the next issue will be going in terms of what is guiding us of where we stand, the issues around mortality, and last but not least, the current issues that we are facing with Omicron, and then again, the take-home messages. But I thought just to start this, unfortunately, we are in the middle of all of these cases, and I thought maybe one of the cases that might highlight some of the issues around how to manage trauma patient would be this one. It's a young man that has come in. It's a very early hours of the morning. Initial blood pressure was 122, as you can see, drops a little bit to 65s. He's cold, he's clammy, he's certainly having a pH of 7.26, base excess of -7, and lactate of 5.1. When you look at the mechanism on the X-ray on your right, you can notice that unfortunately he's been shot 4 times, minimum of 4 times. At least 3 of the wounds are all parasternal, and one of the wounds has gone higher up on the chest, and that wound had managed to go on and affect the arm on the very same side. And certainly in our unit, a patient that came like this, there's no way that the classical COVID signs and symptoms will be relevant to us. And just like everybody else, we had already made sure that at that stage, this patient, we were going to manage him using the protocols for PUI and make sure that everybody is appropriately wearing the proper PPEs. We managed to give him a bit of fluid and got him well enough to go to a CT scanner that was just within our emergency department. And again, with those multiple guns and multiple bullets that you could see, it was important for us to get an idea of where the issues are so that we can manage him very well. And you can see some of the bullet has gone through towards the back of the chest, another one towards the side of the chest. But again, that picture was showing you more that were also in the abdomen, and we needed to make our way forward and deal with the rest of the care. There wasn't any significant pericardial fluid on the scanner. And again, on ultrasound as well, hadn't picked up any significant fluids. And the rest of the abdomen, other than the gunshot that had gone through the chest and the abdomen to the back, there wasn't a lot of free fluid. And certainly we needed to make our way through and decide on how to manage these patients. I'm sure at this stage, most if your CT scanner was far, you might have opted to go to theater first, but certainly for us, the information that we gained from the scanner, you can see another bullet that is left somewhere in the area of the pancreas there was very, very important to help us to decide on the way forward. So common questions that we asked ourselves as we were resuscitating this patient was again, which cavity should we start with first? Should we go to the chest? Should we go to the left or the right of the chest? Should we go to the abdomen? And certainly that was the way that we approached this patient. Needless to say, he was operated in a COVID IC theater where we were ready to deal and manage him and intubate him according to the standard of care then. We certainly had to start with a laparotomy. The liver injury was sorted out. The pancreas was bruised. We decided at the end of the day that we're going to leave it with a drain towards the tail of the pancreas and the head of around the area of the head of the pancreas. Then we proceeded towards the chest because you could see that there was still significant blood on the right side of the chest. And we opened up the right side of the chest, and lo and behold, we found that there was also an injury to the atrium, and the rest of the other 3 bullets we could remove, except the one that was deeper to the pancreas. And we thought that there was no point in dealing with it at that stage. But just to summarize, a liver injury, pancreas injury, significant injury to the lobes of the middle as well as the lower right lobes, as well as an injury to the heart involving the atrium, and we were able to manage those things. But you can imagine operating on this patient with a lot of highly aerosolized areas around the lung, with that bleeding bronchus as well as leak of air from the bronchus. And at that stage, our results came back and we noticed he was COVID positive, and it was glad, and we were glad that we had followed some protocol over the way that we approach him. And just in case you are not aware, those are the parasternal gunshots, including the epigastric gunshot, and the other gunshot is higher up. And as you can see, we still have left one bullet in him. And the post-operative care was also a little bit difficult for us. Was it the COVID that was starting? We constantly had to realize that as much as we were managing trauma, we needed to make sure that we are looking after and making sure that this patient does not become more COVID-related pneumonia, because some of our patients have done that and we lost them, or we dealt with them with the issues related to COVID outcomes. And he continually improved. And again, our approach to the chest physio, where he was managed, which was not in the trauma ICU, but the COVID ICU, came with some of those realities that we needed to be able to adapt. He was complicated by some effusions in the chest, and we were able to manage these with the simple drains and subsequently with some of the aspiration. And the long and short, he continued to do well, and we still left the situ, and he was actually ultimately extubated. And at 6 weeks on follow-up, you can see that that patient, despite COVID, despite having multiple injuries from trauma, we were still able to assist him and follow what needed to be done. And the arm was ultimately sorted out by orthopedics while he was still in hospital after we sorted everything else for him. So yes, we have been finding ourselves to deal with trauma. Certainly the hospitals that I'm involved with, we have a lot of trauma as well as COVID positivity. And yes, throughout, and now we are on our 4th wave, we have had to deal and manage them from a trauma perspective. But if you look at other guidances from our country, you can see that one of the things associated with the lockdown was that for the first time, we could take a break as trauma people for a while because our numbers in trauma were decreasing. The reason was our lockdown was associated with restricted movement as well as restricted alcohol. And in the South African context, you need to understand that most of the trauma we see is related to interpersonal violence as well. And that was shown again, another different study, and this was done in Cape Town as well, showing you that over the period of time, there was a significant decline in the trauma, except that as soon as you allowed for more people to come out, the numbers started to rise. And the involvement was not only gunshot, stabs, blunt trauma, but all different types of trauma deteriorated or decreased depending on the severity of the lockdown that was followed. But lo and behold, as things turned out, people still went back to their ways and ended up with issues relating to the numbers. The other issue that we noticed is that, again, as it was said earlier on, some of the patterns we noticed as the lockdown continued, we started to see a lot more gender-based violence as well, increasing as the other incidences were decreasing overall because, again, of people being frustrated in closed spaces and dealing with that number of trauma cases under those circumstances. And that's not us only. I mean, this is a study from the UK as well that had shown in terms of facial injuries that their numbers had dropped significantly during those lockdowns. Another, again, good study as well, the ICON trauma study, that has shown you that pre and post this period of lockdown, you were looking at significant deteriorated numbers. And somebody might ask, but what has happened to the mortality? Has the mortality worsened in these cases? And again, different opinions around the issues on mortality. I enjoyed this paper, which was a JAMA paper. And if you looked carefully at it, at about 7,000 cases over those periods that they were looking, and they were analyzing about 15 centers in Los Angeles County area. And it was interesting that when they looked at their numbers, contrary to what I had presented before, they didn't seem to show any major differences. Neither was their mortality really affected by the issues of COVID pandemic, plus minus the issues of the lockdown. And I think it was interesting to see when we were reflecting on what we were seeing in our environment. Different studies, and this was on orthopedics again, showing that in their opinion, mortality went down. But if you dig deeper, you realize that because of their numbers that they were down, it made sense that their mortalities related to trauma were down. And another study again that was based on Guangdong in China, and they were just looking overall in terms of epidemiological study, and they thought that statistically their numbers of outcomes and mortality were less. And again, if you look at the numbers of people that were presenting, had decreased, except for a few cases where there was increased falls from heights or self-harm on specific population under those conditions. So there is no doubt that COVID has had an impact on trauma, and this is what we have seen. And again, as we have lost some of our healthcare workers who were going to assist in the heavily loaded areas of COVID-19, we still had to make sure that we don't miss that balance between zero preventability of preventable death, as well as being able to find that balance between trauma care as well as COVID-19 management under those circumstances. And we looked at all of those issues. And again, this was one of the studies that had said, how do we think about managing trauma when we are having these different periods of pandemics, and how to work around it? And all of us had to go back and look at some way or one or the other of looking at our flow protocols and seeing what we can adapt. And I just wanted to give you this one that was based on Singapore. And again, the whole issue, is the patient stable or unstable? Because on other guidelines, this will not be taken care of. And again, the more unstable the patient was, the more you needed to manage them as though they were COVID-19 until the results came back. And if they were positive, you end up sending a patient to an ICU that might not be trauma orientated, and you must watch the protocols around that. The other patients that can talk to you that are not comatose, you are able to screen them, and we would put them in a PUI ward, and then after PUI ward, be able to take them further from that point of view. And I enjoyed as well this other paper, although you might disagree with their key issues. But again, another study that was saying, look at your normal trauma care and adapt it to what is being said in terms of recommendation for COVID-19. And when you look at it, they notice that when you are following other international guidelines, you are gonna miss patients that are asymptomatic but positive that come to your unit in trauma. And you need to constantly reevaluate and constantly check for symptom change. And constantly, we swap all of our patients in the middle of a pandemic until such time that we have a result, they are kept in a special unit. We had all of us, and I'm giving you this example, which was a New Jersey example, had to adjust our resources such that our PPEs, and it was very interesting for me to notice that they also had a problem with the availability of PPEs, but that our PPE utilization is centralized. We were able to realize that every new patient could be potentially COVID positive until proven otherwise. And when you centralize your way and management of your PPEs in your emergency department, you may be able to lower down and reduce the impact. I think from our point of view, we noticed as well that it was important early on, because most of us are serving in those committees in hospitals that help to adjust. It was important to add that visual aid, a signage, so that people can know what is it that they needed to wear in an appropriate area, And certainly early on, there was a lot of concerns about how this virus is spread, etc. But the least we owe was to protect our eyes, to make sure that we have visors, use appropriate aprons. And I'm sure most of us now are aware that some of those issues are under challenge. When we were dealing with it from trauma, the other issue that we needed to be aware of was the highly aerosolized procedures, the intubating of an unknown patient, the intercostal drain of a patient with a major pleural leak. And we needed to make some adaptation, and you can at some stage look at this study that made you aware that the more bubbling the intercostal drain, the more aerosolized potential it had, and we needed to be clear and aware with it. I want to finish with this 1 or 2 slides, and again, just telling you about our new experience with the Omicron. Yes, I'm afraid it has started in different areas. I believe we described it early, and it was given the South African name, but anyway, leave that as it is. Unfortunately, it's very highly transmittable. We are seeing younger patients that are coming in the country where there's only 40% vaccination uptake. Even those patients that are people that are vaccinated, we are finding breakthrough infections. And I'm asking you that, again, be careful about it. We haven't seen more hospitalization, but we have lost in our hospital in 2 weeks, 10% of our healthcare workers were affected. And by the way, more than 50% of them had been vaccinated. So the message is still keep your distance, still wash your hands. But as this virus is mutating, we're going to find ourselves with more and more of these, and we're going to need to be boosted and have multiple boosts for the COVID-19. So I think at the end of the day, I think COVID-19, we agree it's a global pandemic. Yes, we must follow trauma, but we must incorporate the COVID-19 protocols and remember that the unconscious patient is high risk. Keep your emergency department as a PUI until proven otherwise. Every highly aerosolized procedure must have appropriate PPE. Stay vigilant. And again, I think the challenges and the risks is when your manpower, your healthcare workers are affected, that can have significant impact in terms of the outcomes and how you are able to manage the rest of your trauma. Thank you very much for the opportunity. I will hand over back to the chairman. Much appreciated. Thank you.